So today we'll look at Ebstein anomaly, and even it's not very common, but they love this on the exam as well. Okay, so you need to know a little bit about Ebstein anomaly. So we will do the classic definition of Ebstein anomaly. Okay, so Ebstein anomaly is I'm going to just talk about it in general, and then we'll look at the classic definition of it. So it's a situation where the tricuspid leaflet is apically inserted into the right ventricle. It is lower in the right ventricle than normal, to the point that it looks as if there is no RV. Because it's so low into the ventricle, you have a huge right atrium and a very small right ventricle. When you look at Ebstein anomaly in detail, you find that the septal leaflet is the one that's apically displaced. It's lower in the ventricle, and those patients tend to have significant tricuspid regurgitation, large amount of tricuspid regurgitation. So that's the basic definition. So the classic definition now is the septal leaflet of the tricuspid valve is displaced towards the RV, right ventricular apex. And the right ventricle, so you're going to have right ventricular myocardial abnormality because the functional right ventricle is going to be small. Okay, just think about it. So the functional right ventricle is going to be small. So what are some of the associated conditions or lesions associated with an Ebstein anomaly? An atrial septal defect or a PFO occurs in about 50% of these patients. So an ASD or a PFO is very common. A lot of these patients have Wolff-Parkinson-White syndrome. And if you remember from your arrhythmia lectures, you have a bypass track, which takes impulse from the atrium directly into the ventricle. Okay, so that's what we call Wolff-Parkinson-White syndrome. When you look at the ECG, these patients have a right bundle branch block and a first degree AV block. So these are some of the associated lesions. So this is a case of Ebstein anomaly, and this is the tricuspid valve here. It's so low in the right ventricle, and this is the right ventricle right here. This little thing here. All of this is the atrium. Okay. Basically, what you have is the septal leaflet of the tricuspid valve going all the way down into the apex. And these patients have tremendous amount of tricuspid regurgitation. And they can have some amount of ASD or PFO. Okay? All right. So when you look at your echo, what are you going to see on the echo? You're going to see a large right atrium. Okay? You're going to see a very small right ventricle. So just think about it. You know, the tricuspid valve is lowermost in the ventricle. So the ventricle is going to be small. The atrium is going to be large. The classic definition is the displacement index. So when the displacement index is more than 8 millimeters per meter squared, that is one of the conditions that have to be satisfied. And what is the displacement index? what we mean by the displacement index. All displacement index is the linear distance between the septal leaflet insertion of the tricuspid valve and the mitral valve, and you're going to divide it by the body surface area. Remember, when you index anything, you're going to divide it by the body surface area. So basically, what you do, all right, let me draw that so you'll have an idea. So that the displacement index. So if this is the ventricular septum right here, and this is the left side over here, and say this is your mitral valve right there, okay? And if the right side is right here, and this is the septal leaflet, okay? The anterior leaflet is going to be probably higher up, but the septal leaflet is apically displaced. So this is the ventricular septum. This is the apex right there. So this distance, you're going to measure this distance. The distance between the mitral valve and the septal leaflet of the tricuspid valve, the insertion, you're going to measure that. And say you get 10 millimeters, then you're going to divide it by the body surface area, okay? So you use the patient's height and weight, and you'll get the body surface area. So if the body surface area is 2, and you divide 10 by 2, you get 5. So it will be 5 millimeters per meter squared. So that is what we call the displacement index. Again, these patients are going to have a significant amount of tricuspid regurgitation, and 50% of your Ebstein anomaly patient will have an ASD or a PFO. So you have to remember the definition, especially for people who are doing exams, okay? When you're scanning, all you have to know is that the septal leaflet is going to be apically displaced. You're going to have a very small right ventricle, a huge right atrium, and significant amount of tricuspid regurgitation. All right, so again, we will look at actual examples of these. Okay, so this is not plain, but we'll look at the actual example. So this is Ebstein anomaly. We're going to look at tetralogy of Fallot. We're going to have a separate session, however, to look at cases of tetralogy of Fallot and repair TETs. Okay, so our next session, when we're looking at cases, we look at cases of coarctation of the aorta. We look at Ebstein anomaly. We already saw anomalous venous return, I think, and PDA. But we're gonna have to do tetralogy of Fallot separate, because you have to have a fair understanding of tetralogy of Fallot. So what is tetralogy of Fallot? Tetra means 4, okay? And, you know, some people talk about the pentalogy of Fallot, but, you know, you'll see mainly tetralogy of Fallot. So there's four abnormalities. And one is pulmonary infundibular stenosis. Okay, there's stenosis of the right ventricular flow tract. You have an overriding aorta. You have a ventricular septal defect and a right ventricular hypertrophy. Okay, so these are the abnormalities that form the tetralogy of Fallot. Pulmonary infundibular stenosis, that is where you have the right ventricular flow tract, it is stenotic, and you can have varying degrees of stenosis. So the indication to intervene in a patient with tetralogy of Fallot is dependent on the amount of pulmonary infundibular stenosis, the amount of stenosis you have at the right ventricular flow tract. That's going to determine whether you do an intervention, yes or no. If you have minimal stenosis, then the patient will do well and you probably don't need to do much. If you have significant stenosis, then the patient will not do well and you have to do some type of intervention. These patients have a ventricular septal defect with the aorta overriding the ventricular septal defect, and that's why it's called an overriding aorta. And then because of the pulmonary infundibular stenosis, the blood cannot get out of the right ventricle hypertrophy. It thickens. Okay, so this is a cartoon which explains what's going on. This is a normal heart. Okay, the right side of the heart, the right atrium, the tricuspid valve, the right ventricle. You have the right ventricular flow tract is right here, pulmonary valve, the pulmonary trunk, and then you have the main pulmonary branches. Okay, so when you have, and of course the ventricular septum, the left ventricle, left atrium, the aortic valve, and the aorta. When you have tetralogy of Fallot, so the right ventricular flow tract, there's stenosis right here. So, and again, you can have varying degrees of stenosis, and this is going to determine whether you intervene, yes or no. The degree of the right ventricular stenosis, right ventricular flow tract stenosis. And because you have stenosis right here, okay, then the right ventricular hypertrophy, you can see thickens compared to the normal. This thickens, it thickens. You have a ventricular septal defect. It's your normal ventricular septum. There's a ventricular septal defect, and the aorta overrides it, and that's why we call it the overriding aorta. Okay, so pulmonary infundibular stenosis, 1, right ventricular hypertrophy, 2, a VSD, 3, overriding aorta, 4. So these are the 4 conditions that make tetralogy of Fallot. Okay, so what are some of the signs and symptoms that these patients are going to present with? And again, a lot of these patients are going to present in infancy or childhood. Okay, so if a baby is born with tetralogy of Fallot, you will intervene if the infundibular stenosis is very significant and blood cannot get into the pulmonary circuit. So if it's very significant stenosis, you're going to operate on that baby as soon as possible, lest the baby won't survive. Okay? If the stenosis is not significant, then you can wait a little bit. Okay? So you have low oxygen saturation. Okay? It can be cyanotic because the blood cannot, the deoxygenated blood cannot get into the pulmonary circuit. So blood is going to flow across that ventricular septal defect into the left ventricle and then out through the aorta. So you're going to have deoxygenated blood in the aorta, so the patient's going to look blue, so cyanotic. Failure to thrive because of the cardiac defect and decreased cardiac output. Shortness of breath, because you have decreased cardiac output. Digital clubbing. So when you look at the digits, the fingers and the toe, there is a type of puffiness, and we call that digital clubbing. Polycythemia because of the deoxygenated blood that gets into the systemic circulation, and it's going to stimulate increased red blood cell production, and that's what we call polycythemia. Okay. So when you do your echo, you're going to see the VSD. It's going to be there. You'll see you're going to have right ventricular hypertrophy, because that's one of the things that you'll get. And you're going to have varying degrees of right ventricular outflow tract obstruction. So you're gonna, you do your gradient and you'll see obstruction. And then the Doppler will, you can have branch pulmonary artery stenosis, and can have significant pulmonary insufficiency as well. Okay. So this is the short axis view at the level of the aorta, and so you can have you can have significant right ventricular flow tract obstruction. You can have stenosis of the branch pulmonary artery. Okay, so you wouldn't make your diagnosis in a parasternal long axis view, but in a parasternal long axis view, you can see the ventricular septum, you can see the ventricular septal defect, and you can see some degree of overriding aorta. Okay, so you need all the views. So the 4-chamber view will probably show, or the 5-chamber view will probably show it best. So when you have a baby with tetralogy of Fallot, you're going to look for other defects, and you can get, as we mentioned, branch pulmonary artery stenosis, and you can get stenosis of the left pulmonary artery in about 40% of these cases. So left pulmonary artery stenosis, because the right ventricular flow tract is stenotic and it can extend down into the branches. You can have bicuspid pulmonary valve. Remember the pulmonary valve is supposed to be tricuspid. So you can have a bicuspid pulmonary valve in 60% of patients. You can have a right-sided aortic arch. Instead of the aortic arch going to the left, it can go to the right in 25% of patients. Coronary abnormalities, that is where the normal thing is that the right coronary artery arises from the right coronary cusp. The left main coronary artery comes from the left coronary cusp. So you can have, you can have you can have varying abnormalities of coronary artery origin. Okay, so the right coronary artery, well, the right coronary artery may come from the left coronary cusp, or the circumflex may come from the right coronary cusp. So you're going to look for abnormality of the origin of the coronary arteries. Again, ASD or a PFO can occur. Atrioventricular septal defect, this endocardial cushion defect. Anomalous pulmonary venous return, you can have partial or total. And skeletal abnormality, scoliosis. So these are some of the additional defects that can occur with tetralogy of Fallot. All right, so what we're going to do, we're going to stop here. You're going to go over these things in depth.